Andrew Stevens. I'm a fourth year medical student at the University of Utah, obviously, and excited to be going into family medicine. I just actually finished a sub-I last rotation at McCady, so yeah, I'm excited and for this interesting interview cycle that's going to be. So my research project is looking at essentially patient satisfaction. Measuring patient satisfaction is something that has increased in importance over the past decade or so, especially as policies like legislature policies allow patient satisfaction to be used in connection to reimbursements and for physicians and for hospital compensation. And it's becoming more common to view patient satisfaction as a surrogate for measurement of value of care. Obviously, I think there's a lot of value to this, but a lot of weakness to this, as recent studies have demonstrated that there are a lot of non-modifiable factors that influence patient satisfaction, such as age of the patient, gender, race, how far a patient lives from a clinic, as well as these modifiable factors such as like wait time, etc. And the purpose of my research project was to evaluate the Ganey survey, the Ganey Outpatient Medical Practice Survey, which is a commonly used survey to measure patient satisfaction in the outpatient setting. It's something that we use at the University of Utah. It's composed of 25 questions, 10 of which relate directly to the provider. The remainder relate to other aspects of the encounter, such as access of care, ability to get an appointment, factors related to the staff, and other areas like related to just the encounter in general, such as privacy, safety, etc. And so we wanted to look at the likelihood of each individual question to receive a perfect score, or to receive perfect satisfaction. And we did this by collecting all new adult encounters at the University of Utah between 2014 and 2016. And they were adult patients, and there was like a new unique encounter. So if patients had been seen by any other provider in the University of Utah healthcare system, they were excluded to remove that bias that they had already maybe had a positive experience or a negative experience at the University of Utah. And so we had collected about 5,000 patients that had completed the Ganey survey and evaluated their responses. In Table 1, we have each individual question. And another thing is that we define perfect satisfaction as them giving 100 on the individual question, just given the large ceiling effect of each specific question. So in Table 1, we have our top 5. Maybe good to zoom in to the rows highlighted in green if we could. Thank you. So the top score, receiving about 85%, was the provider spoke in using clear language, followed by provider was friendly or courteous, followed by the nurse was friendly. Then how confident they were in the provider's assessment, and then the likelihood to recommend the practice. Oh, and the question just popped up that these were collected for just family medicine or out encounters. And then down at the bottom, in red, we have the bottom 5, which relate more to the ability to obtain an appointment, such as convenience of the office hour, ability to get the appointment, ease of getting the clinic on the phone, wait time, and information about delays. So I think generally our results demonstrated that the majority of provider-specific scores were scored favorably. The only 2 that made it even in the bottom 10 related to like the provider's information about medications and instructions for follow-up, where the remainder of all the provider-specific scores were more or less in the top, or more likely to receive a perfect score. And then obviously the bottom 5 relate more to ability to get ability of like wait time or ability to get the appointment that they desired. So I believe our results demonstrate that the areas for improvement or areas for improving patient satisfaction generally don't relate to the provider themselves. I don't think it's necessarily that the provider needs to be uh, more understanding or friendlier, but rather it's the overall experience of wait time. I think has always been a big killer and will always be a big killer to patient satisfaction scores. Because I think healthcare administrators and systems can take these into account, especially when advocating for how patient satisfaction um, should be affected by policies, how they should be connected to reimbursements, as well as this is just a good opportunity to evaluate what things we can do better as a healthcare system in improving patients' experience in the clinic. So, any questions?
We do. Let me go ahead, and we have two different questions. Dr. Jensen asked, in what services or departments were surveys conducted?
So these were so at the University of Utah, the university has contracted with Press Ganey, and so every patient, any outpatient encounter, they receive an email 30 days, or they receive an email within like 5 days after their patient encounter, and then that survey link is live for 30 days. So every patient who comes to the University of Utah receives an email. We specifically looked at those who had seen a provider, a physician who had conducted or had completed a family medicine residency. So we looked at family medicine specific department.
Great. We also have a question from David Cook. Can team-based care help with improvement in the waiting room, phone experience, etc.?
Yeah, that's something I've thought about. I don't think there's a lot of research, but as I've evaluated these scores, I think an interesting follow-up study would having someone, maybe a staff member, I don't know, like follow up with the patient saying like, hey, expected wait time is like 10 more minutes, or, we're going to, just because like wait time, I think has always been something that is heavily connected with low patient satisfaction, like the longer they wait. And then information about delays too, I think surprisingly in our study was lower, probably not significant, but I do think that having maybe some sort of system where patients are just updated regularly would probably negate a lot of the dissatisfaction in that area.
Great. Dr. McGill has asked, ceiling effects are common in these surveys. What is a meaningful difference in results?
I think that's hard to say. We in this abstract, I think include we also did like a Spearman correlation to look at which questions specifically relate to the likelihood of a patient to recommend the practice. And it's not something we include in the abstract, but we're going to include in the manuscript, which I think demonstrates that a lot of the scores that are provider specific actually relate pretty strongly to their likelihood to recommend a practice. So I think it's hard to say like a meaningful difference between the individual questions. But I know that with as far as reimbursements go, that there's like a certain cutoff that if you're below like the 80th percentile, you get dinged, and the mean for Press Ganey score, the overall score, is somewhere like 94%. So it's actually very high, and so just like getting dinged in any one of these areas can, I don't know, be seen like you could have a really high score but still have a pretty low Press Ganey score as far as the eyes of I guess in comparison to peers.
Great. Last question from Dr. Lee. What do you think about the study that the higher patient scores actually correlated to worse care? Showed patients rank physicians higher who give out a lot of narcotics, but this leads to overdose, hospitalizations, etc.
Yeah, I think I actually read that paper, and we're going to do a similar one with Press Ganey, looking at opioid usage. We're going to be utilizing the Utah Department of Health's database, looking at like morphine equivalents and seeing if because I don't think that study looked specifically at morphine equivalents. And there was actually another study that came out recently saying that patients who are offered surgery are more likely to be satisfied in like an orthopedic setting. And so I think that's quite discouraging, that things that I think it demonstrates that patient satisfaction isn't a measurement of the value of care given. And if we see it that way, it may lead to, hopefully not, but it could lead to providers recommending things that may not be necessary, just out of the hopes, they want to satisfy their patients rather than provide them with the appropriate care.